At this point in time, we're going to begin a panel question and answer session, so this is very simple. We're going to invite our speakers back up to the table. You guys can go ahead and have a seat. Again, Dr. Bain, Dr. Trey Ellis, Dr. Benke, Dr. Roche, and also Dr. Nisha Haku is on our medical advisory board. She's a GRIN2B parent as well. She's a pediatrician. They're going to be here just to, if you have any questions that weren't answered before, if you have things that you would like to discuss, this is basically open time for about the next 45, 50 minutes or so. If you have any questions for all of the speakers, this is the time. Panelists, because we only have one mic here, we're going to have to do a pass around. And if you would be so kind, and if you forget, it's okay, we'll do the best we can. Try to maybe rephrase the question before you answer it, just because I don't have multiple microphones. I would like to make sure that we understand, subject and answer. So, all right, thank you guys. I'll set this down and we'll just kind of raise hands and get going. So, and thank you all again for your time.
So should we select the people?
Sure.
Who wants to go first?
Yeah, Jeff, go ahead.
I'll go first. So one of the discussions that was happening in the pool A room was centered on something that I don't think has been touched on today, but maybe best for the pediatrician in the house, I don't know. But it relates to some of the facial features. And one that's common in my son Nolan, who's almost 7, is the dark eye circles. It's been related to allergies, but I see it across the board, and I'm assuming that we're not all eating the same things. And so I didn't know if there's anyone who's looking at these sort of features as it relates to GRIN2B. But it certainly shows up as a very common feature amongst our Facebook group photos.
We were just talking, so the question was about facial features and dark eye circles. I think we were just talking about that as well, that there does seem to be some commonalities. I think from the literature, at least what I've seen thus far, there is not anything documented. But certainly, there are similarities that we've all seen.
I'm not a primary pediatrician, though from my pediatric training, I would say that I think you might be right in that if rhinitis and if allergies does seem to be a common theme that everybody has, and that we do see that commonly with the dark eyes, maybe that is playing a role. I think from the Simon's database, we have a good amount that, yes, allergies is certainly something that a lot of children are suffering from, but the facial features haven't yet entirely been elucidated upon. I'm not sure, does your group, have you heard of Face to Gene? Yeah, I'm not sure if your group. Yeah.
Our geneticist actually took our son's photo and ran it through that database.
So it's a database that basically is taking facial recognition software. I don't know whether there is something facial out there, but this is something to consider as a group, whether or not you would want to donate those pictures and see whether there are common themes in terms of facial recognition, which would allow or facilitate finding more families, etc. Just a thought.
Just looking at some of the data that the Simmons group presented, I don't think that there's an abnormal amount of kids that have allergic rhinitis or ear tubes or any of those other kind of things. Those are very, very common things in the general pediatric population as well. So,
my question is, let's see, in all of the data that was presented from Simon's VIP, a lot of the things that I see that are the most salient for my daughter would be around social things, fearlessness, emotional, erratic kind of emotions and things like that. I know those aren't as quantifiable or as easy to put in a chart. And Tim, I think you asked about that for survey purposes. So often some of the questions don't really hit what I feel to be Sadie's biggest challenges and our biggest questions. So are you looking at some of those, maybe what you would call softer factors or something like that? I don't know. Does that make sense? My question?
So the question is, are the data instruments that we're using, are they really capturing what's important to you?
Yeah.
And so I'll speak to a couple of things. First of all, so when you get the survey instrument, because I know that you're all going to email Austin and send him your genetic reports and sign the consent, then he's going to send you the form. It's a paper form. I know that's a bit of a dinosaur thing, but it does have its pluses and minuses. For some people, it would be easier to fill in something electronic. But if you fill out the paper form, you can write down whatever you want to write. And I think that would be helpful. If you think that it should be helpful to me and you want to put it down there, go ahead and put it down there. And I'll look through there, and what I might have to do is just adjust our data instrument. Yeah, there's a few hoops that I have to go through because I have to let the IRB approve what I'm collecting. But if I'm getting stuff that I wasn't expecting and it's already there, even though it wasn't a slot on the form, it's helpful to me because there are some free form areas where you can put things on the forms. And so please just go ahead and do that, and then we can adjust things as we go. The other thing I wanted to say is that at the moment it really is two separate databases, and so we want you to do both. We can figure out how we can link these up at some way in the future, especially so that we're not double counting our patients. And I know it is a lot, but it is two different databases that we are asking you to do, and I know that's a lot to ask you to do. So.
But we appreciate it. So just to reiterate, I would say from the Simons perspective, so we're working in parallel, right? Simons is really kind of the overarching to help many genetic groups like this, but we have to work together in order to collect the data. So yes, the information will be the same. And as we mentioned earlier, we're starting with a really broad net, and then as we start to learn and tailor what are the issues that really are concerning to you, then things will get narrowed down. And I would imagine Jennifer, after I speak really quickly, might say something along the lines of, if this is important to your group, Simons can work with you, and the foundation can say, this is a survey that we think would capture our concerns more closely, to send that out. What I would say is, from a research perspective, questions that are important to the patient are unlikely going to relate really well to what's out there in the literature, okay? And that's just a matter of a researcher. We try to be objective, we try to be validated, we try to gather information in a safe manner in order to say yes or no. And so while your answer is unlikely yes or no, it's easier from a scientific, numerical perspective, quantitative perspective to be able to do that. So utilize the fact that you have these areas to be subjective and be qualitative to describe, and then work with the researchers to say, okay, how do we put this in a quantifiable manner in order to do the research, in order to do this, and then how do we actually compare A to B instead of just comparing apples to oranges? And a lot of the studies out there might not have an anxiety scale that's been validated for neurodevelopmental disorders. Okay, so why don't we go and take a common sleep study and bring it into this group and say, how does that differ from the other groups? And so the utility of, yes, tailoring it towards what your needs are is important, but understanding that the reason why researchers might not be using the tools that you think is applicable is because those are tools that have been what they call validated in the scientific world to say, yes, these are useful tools and they're meaningful tools. So in order for us to do that and to get to that point, we need your information in both of these wonderful research studies.
I just want to add, so just to reassure you, we do, so for the purpose of the presentation that Dr. Bain gave today, we would have been here for hours to give you all the results that you guys have so generously provided us with those answers. We do have, and our clinical psychologist who manages our battery of surveys isn't here today. She could go into much more detail, but we do have surveys that have been used in autism research and other neurodevelopmental disorder research. So we have the child behavior checklist that would get into internalizing and externalizing behaviors. We have the social communication questionnaire. We have the social responsiveness survey. So if you probably have experienced surveys online that have been asking about your kids' behaviors and sensitivities, that sort of thing, and that data was not included
Okay.
in here. But it sounds like that would be helpful for you guys to know. And I'm wondering if it's that partnered with medication use or just in general, what is the incidence and prevalence of these behaviors in the cohort? But we can definitely pull some of those numbers, right? Yeah. And actually, and other researchers, Tim and anyone else can use that as well. So if we put a link in between the two studies, he could take all the information that you're providing him and add the other stuff that we've also collected from you for analysis.
Doing that is also a nice external check to make sure that the data that we're getting is valid.
I think from like a general pediatric perspective and also like as a parent, I think there's sort of two realms. There's trying to figure out our kids from a scientific standpoint and what's actually going on with their mutation and how does that trickle down into the protein effect and how that changes their learning, their memory, their safety awareness. And then sort of kind of where we're at right now, which is sort of the more practical aspect of it and how do we keep our kids safe from not running into the middle of the street and so on and so forth. So, I mean, I think that, a lot of kids with multiple different disorders or etiologies or reasons for safety awareness or regulation, we can sort of draw from a lot of different groups and a lot of different kids with a lot of different developmental disorders and sort of utilize techniques that are working from a broader perspective to kind of make our kids happy and functional and safe in the meantime, while people smarter than I are working on figuring out, more better ways to sort of treat the underlying problem.
I saw a lot of reports of sleep issues for children with GRIN2B. I know Kate sometimes goes all night, doesn't sleep at all. She'll go how many hours? 36 hours and not sleep. And how do you, anybody, I only saw one person put melatonin down, and I don't know that any of that ever even works. So any recommendations? Is there a physiological reason?
So that's a great question. There are a lot of disorders that do have sleep issues like that. You try to put your best spin on it. You call it, she's having another all-night party, rave, whatever it is. But they can sometimes, go on for days. So talk to your pediatrician. There are different things that are suggested. That's a lot of times why clonidine is used. Melatonin is good for sleep initiation, but not necessarily sleep maintenance. So there's other things that you can try instead. Clonidine, again, it's more sleep initiation, not maintenance. Some of those things that are going to help more with sleep maintenance are going to be like trazodone. Not a lot of times your pediatrician is very comfortable in doing things like trazodone, so you may have to work with your neurologist or a sleep specialist who is a little bit more comfortable in doing things like that.
And I'll add too, what I'm going to say is anecdotal to my daughter, but Lucy has sleep issues as well, and we did put her on clonidine in May of this year, and it has been greatly effective for us. She almost always sleeps through the night now without issue. Any side effects associated with the clonidine, again, for us seem to be pretty minimal. And sometimes, because we're traveling somewhere unfamiliar, we double it up. We're doing melatonin and clonidine because we're staying in a hotel or out of our own bed. But for what it's worth, it has worked for us.
So what I would say is that knowing that everybody's coming from different places with different resources, with different people who are available to them, and secondly, that you are unlikely going to just walk into a random pediatrician's office to say, I have GRIN2B, GRIN2B. And they're going to be like, of course, I know all about GRIN2B. I know all 58 people with them. But you're not going to find the expert in that field. What you will find are people who do deal with many children who might have sleep issues caused by maybe a variety of problems, and that's okay, and they probably do have some tricks up their sleeve. My recommendation as a clinician is to say, find the person that you trust, right, and who's willing to go through it over time, because it's not going to be an overnight fix. You are all going to try every single thing. You probably have tried every single thing, and you probably wanted to do it all at the same time, right? But realistically, that's not going to work. And that's from me being a scientific person saying, you can't try, you've tried melatonin separate, you've tried clonidine, okay, fine. In certain situations, I probably would do the same, do both together. But you're not going to go and throw your whole kitchen sink at the same time. Because then how are you going to know what is actually making the difference, right? So in general, I'm sure most of you have worked with like behavioral therapists or sleep therapists, thinking about like very basic lifestyle modifications. Many children with neurodevelopmental disabilities, including this group, do well with routines and bedtime routines, very simple things, right? Lavender oils, soothing music, white noise, whatever. So you do that. You have it all. You try everything that you're able to do without taking out the second mortgage, right? And you try that for a certain amount of time, right? If you are going through it and you've done your 6 or 8 weeks and it's just not making the difference, and you say, okay, now what are we going to add to this recipe to see whether or not make that change? When you decide to make those changes to the recipe, talk to your provider who's going to be the person throughout. You can't be jumping between 5 different people and taking 5 different people's advice, because no one's going to be able to help make a way out of that, okay? And then ask them, how long should I expect until I'm going to see that change, right? There are some medications you're going to see a change overnight, right? And there's certain medications that are going to take 2 or 3 weeks to maybe kick in and see that effect. And what are the side effects you expect? And what are things that you're not really sure whether to expect or not? And feel comfortable with whoever the providing caretaker is, the clinician, to say, okay, is this from GRIN? Is this from the medication? Or is this just my kid being my kid? Okay? And changes in your environment can certainly change sleep a lot too, whether that's new school, new people, new baby in the house, going to a conference. So just make sure that you're being realistic with your timelines, honest with your provider, and kind of staying true and trying something for a certain amount of time before switching, because you can't do one med for 3 days and another med for another day. It's just, you're not going to see a good trend.
I want to echo that a little bit. So I do see a disproportionate amount of chronic and complicated medical children, and I'm probably a rare person that does do trazodone and clonidine and stuff like that. And I would say across the board that sometimes it works in some kids and sometimes it doesn't. And like no matter how much I try and like be scientific about making a judgment on that, like every time I think I'm going to guess right, I don't. So some of it is trial and error, and I encourage you guys to think about some of the things that was presented today and think about what's going on in our kids' brains. And they have problems with learning and making those connections. And so sometimes I feel like you just have to hold your breath an extra couple seconds, because they just like, I think at least for my own daughter, like she's never going to get this, or we're never going to jump this hurdle. And then you just kind of wait it out a little bit longer than is comfortable. And sometimes they just sort of inch forward into the right direction. I can't say enough about like just structure and therapeutic approaches. It seems like sometimes even for me when I'm doing it, like this would never work. But, we've done a lot with just surrounding like white noise and weighted blankets and compression and all that stuff. And for me, I think it's a couple different things, and you just have to get that off button off. And so trying to find whatever that is for your child, and then being okay when it goes awry. And I would be the first person to tell you that I derail when it doesn't work, because you think, okay, is this never going to work again, or is it just for today? But your kids are just like us, right? Sometimes we're up all night. Right, exactly. So. Yeah, it's really challenging. I hear you.
And again, anecdotal for us, because when we were going through a really rough patch prior to putting our daughter in clonidine, we started keeping a sleep journal, and just to kind of, because like when you're in it, when you're in the trenches in the middle of the night, like you can't, 2 days later, you can't quite really remember what happened, because, so Liz in her wisdom was like, let's keep a sleep journal. And so we started writing down what the pattern was. And I think it did help at least to sort of get a little bit of an understanding. Because like you said, we all have good days and bad days. And in the case of our daughter, like she's very routine oriented. And she has problems transitioning from one thing to the other. Like we already kind of know, like rough times with our daughter and back to school and done with school, like as a general rule. And so that's something else that maybe you could try to maybe discover that, as you said, that off switch.
Sleep diaries are really helpful if you end up going to a sleep doctor or a sleep specialist, whether that's a neurologist, developmental pediatrician, or a pulmonologist. They usually will actually ask you to take a diary for about a week. When do you go to bed?
When do you go to bed? When are you frequent waking up? Are there any other things? It's similar to any other condition like headaches, where we try to figure out what are the triggers, what can work well and what doesn't work well. But trends over time is really important. It's hard for you in the trenches to see your child make change day to day. And sleeping day to day, but for the physicians and the clinicians who are seeing you every 3 months or every 6 months, we see the bigger change. So when you're kind of in there, it can be really hard, but you'll look back in your sleep diary and say, remember that time we didn't sleep for 3 weeks straight? I love sleep. So you'll get over it. And unfortunately, I think in most of these cases, you have some things are a problem now, and then in 2 years, that might not be a problem, but you might have a new problem. And so kind of keeping up and keeping with the clinician who can bring you through those times is really important.
Go ahead, Benja.
It's been mentioned that there's GRIN medications. What are those medications and what do they aim to assess or correct?
Right. So there are a number of FDA-approved drugs that will hit the NMDA receptor, and they are considered to have that as their mechanism, although they are low potency and hit other targets in the brain. And those include memantine, Namenda, for Alzheimer's disease. That does not change the progression of the disease, but causes a delay in the progression of symptoms for maybe 6 months, depending on the patient. Ketamine is a anesthetic, pediatric anesthetic. Also veterinary medicine uses ketamine a lot. There is dextromethorphan, over-the-counter cough syrup, is an NMDA antagonist, and it's metabolized to dextrorphan, which is a more potent NMDA antagonist, and both of those molecules will exist in your body when you take the cough syrup. And what am I forgetting? There are some others that have been argued to influence synaptic transmission as well, but those are the main ones that I think of. All of those are blockers of the receptor. All of those are non-selective blockers. They will block GRIN1, GRIN2A, GRIN1, GRIN2B, GRIN1, GRIN2C, and GRIN1, GRIN2D, the 4 main types of receptors, and everything that mixes and matches.
It's because they stick in the pore.
And that's because they enter, there's a hole in the receptor that the ions move through to carry the current. They enter the traffic, go through the tunnel, and get stuck. And so they block all of them the same. Those indications, in my mind, would be useful when you have an overactive receptor that you know makes it to the surface. So if you know your receptor makes it to the surface and you know it's there close to normal levels and you know that it is overactive because of that mutation, then logically blocking it might rectify some of the problem. That oversimplifies their use because your brain is plastic, and the moment that overactivation is sensed by the cells before birth, it's already trying to compensate. And so it may have made changes, the brain may have made changes that we can't anticipate and can't test in our simple in vitro systems. And so logically it should tone down overactive receptors, but in an individual, we really don't know what it does. You want to add anything to that, clinicians?
On the back of that answer, what type of doctor can we go to that can make a recommendation on which of these NMDA antagonists might be helpful based on our daughter's use case?
So the way it has worked is this: your doctor would get the report back, and we looked at your report together, and they're going to go, I don't know what that means. It doesn't say anywhere in that report whether it's a gain or loss of function. The only way you know is if they get in touch with Steve through CFIRV or myself, and because we're really the same, and then basically we would submit to CFIRV, a request for functional testing, and then it takes a while for that to go through the pipeline to then decide if it's a gain or a loss of function change in the receptor. And then generally what we do is the clinician, will check back saying, hey, have you finished yet? And then it will be communicated to the clinician whether it's a gain or loss of function. sometimes Steve will go through me to do that, and if they would like to try something, there will be lots of caveats that I will say. There's, you know, there are situations where you might consider doing this, in my mind, as I shift my hat from scientist to clinician. It's experimental. Your child's not an experiment. I would only suggest doing something like this if nothing else has worked, say, for instance, to control their epilepsy. It's like no other drug's working. What do I try next? Well, if you have a gain of function change in an NMDA receptor, it would make sense, if nothing else is working, to try memantine. And so we have basically a protocol that we can suggest to them. If you have medically refractory epilepsy, here's how you could try to see if one of these drugs would work. That's been our protocol for making this suggestion. You know, I think that if you were to say, well, what about if I just want to use something like this for my child's behavior? I think that crosses a line at which, yes, we would like to answer that question, but I think until we have some basic safety data first, it's hard to construct a clinical trial or to do that until we know a little bit more about it. I understand that it's important, but the issue is what is ethically the right thing to do, what is safely the right thing to do in regards to that. Is that fair?
Yes, so related to that point, what if the mutation is on the C-terminal end that Catherine alluded to? So maybe it does not affect the function of the receptor, but just the trafficking. So is there a streamlined process where the parents can find out whether that's whether the clinician can find out whether that's a true gain of function or loss of function mutation?
There is CFIRV runs a assay that is much simpler and very oversimplistic compared to the things Catherine does, and just gives, you know, to the first approximation, a guess whether there's trafficking. But it's a harder assay than some of the other ones, and we tend to be a little bit behind on our time. So you know, we can give that information, and I wouldn't call it a guess. It's better than a guess, but you know, it comes with a lot of caveats. And the work that she showed, which was really incredibly elegant, is time-consuming and hard. And I think it's safe to say it's a very limited number at this point with funding and the technology we have to do that. It's probably not reasonable to think we're going to do that for hundreds of variants. Do you want to add to that?
No, I think what you said is accurate. I mean, in your assays, you'll see in a heterologous cell system, right? So, I mean, if there's something that's so profound about the protein it can't make it to the surface, he might very well pick it up. But if there's something about the variant that is kind of neuron specific, where the trafficking dysfunction has to do with the binding partners that are only in neurons, then that's more what we do, but that's also a lot harder. It's not high throughput. So.
Yeah, and let me add one point that Tim just reminded me. Some of the loss of function variants, either ones that are not prevalent on the surface or that have a defect that just causes them to work less, could conceivably be, you could conceivably improve function by increasing the level of neurotransmitter. And so there's a number of individuals who've brought up the question of serine, D-serine as a treatment, or L-serine, and these receptors respond to glutamate, but they also, I mentioned, have this clamshell that grabs glutamate before they open. They also have a clamshell that grabs glycine, another small amino acid ever present in the brain that's absolutely required for function, and this third amino acid, serine, can substitute for glycine. And so there is the idea that perhaps you could boost function with D-serine. It's not tested in any animal models. It's one of these ideas that logically makes sense in a reductionist system like some of our in vitro assays, and it needs to be tested, but that is another pathway for a trafficking defect or a loss of function.
So there was a paper from the Spanish group about using this, and it turns out they used the wrong enantiomer of serine, and so that paper was subsequently retracted. But nevertheless, it gave some hope that there might be a way to improve function with these co-agonists of the NMDA receptor. And again, you know, you can get serine and glycine from Amazon.com. But you guys are going to do whatever well, but some of you are going to know it anyway, and so might as well just, you know, put it out on the table. I think everybody knows about it, so it's not, I think to not say anything means I'm hiding something, and I'm not. So you're going to try it, but I think that we're concerned that, you know, it could be helpful, but it could also be harmful, and we don't know the answer to that. And again, if you're going to use it, that's where our database is set up, such that we want to capture you before and while you're taking it, so that we can collect the data and understand, was it helpful, harmful, or not, so that we can move from beyond, oh, I heard on Facebook, to, oh, I read it actually in that paper. That's where we want it to move this to a greater level of peer-reviewed, it really works or not kind of thing, such that we can say, well, you know, gosh, we need to do a proper clinical trial with this and address not just epilepsy, but let's address sleep, let's address mood, let's address behavior. I'll get off my soapbox.
Talk on serine real quick?
Sure.
Just a quick follow-up on the serine. Are there any doctors in the United States that are treating patients with serine, or is it just more?
So, Ingo Helbig at Children's Hospital Philadelphia, I think he's considered doing this and we talked about amongst all of us a potential protocol that would be a reasonable one to try. Again, you know, I don't think that there's any data on whether or not the supplements are going to give you any sort of brain concentrations that are going to be anywhere near helpful. I mean, it's really quite empiric. In other words, we don't know. Is that fair?
Absolutely.
Did that answer your question?
Yeah, it did, but just so we're clear, the serine would only be used for loss of function.
Correct.
Yes, it has to be D-serine. It has to be D-serine, because you can buy both from Amazon.
So I just want to take a step back. So I'm really grateful to draw the attention and the risk benefit. Everybody is going to make that decision individually based on your child or your patient with your medical team. But I think that that's a really serious thing, and it doesn't get brought up a lot in parent conversations. And there is reality to that. I also wanted to talk about, there was several slides that came up about, and words that came up about plasticity and the brain's ability to change and to adapt, and that is real. And we do see therapy of all different kinds making those real changes and those connections between the brain cells and those receptors and the amount of neurotransmitters there. So like all those things that you guys are working like so tirelessly with your kids on, those things are making changes. It's obviously, as we all know, it's not a miracle, but it's small things. And you know, we have not seen negative side effects from those things. So it's not futile, those things.
So I would just add, just piggybacking on this, vitamins and supplements, they're not a prescribed medication, but they are something extra. And we do know that, I mean, there's a reason why people are using vitamins and supplements, because there has been historic subjective conversations about them, usually for decades and centuries even. But they do have effects on the body, right? And so that includes the brain. And there are real scientific research about these specific things. So when your clinician is asking you, what are you taking? Don't just say, oh, just some supplements and vitamins. You really do want to just be honest. I'm going to be honest. I have people come into my office every week. I've never even heard of half of the things they're taking, but I write it down and then I Google it. And actually, there is a fair bit of evidence actually and research and in the scientific community, even from the NIH, to actually say, well, what are these compounds? What are they doing? Because they can affect the brain, and they can affect other medications you're on. So just be honest and open with your clinicians about what you're taking and what you're providing to your children.
Just a little comment about vitamins. When you buy vitamins, they're not regulated the same way drugs are. You know, if you get a drug and you think you're giving your child 100 milligrams of lamotrigine, the FDA set goalposts that the company has to hit through as to how much is in there. It's not true for vitamins. If you try melatonin and it doesn't work, you really should switch to brand X, because you don't know if 3 milligrams is really 3 milligrams is really 3 milligrams. The same is going to go true for the serine or glycine or whatever you get off of Amazon as well. It's not regulated. Well, I'm trying to emphasize the unknown here, that you don't know what you're getting. So.
You also don't want to break your bank over it, right? I mean, people say, oh, I'm just
It's another way that doctors can do harm is by causing financial harm. So.
And that's a big harm. People can spend, hundreds of dollars a month on just vitamins alone. So that's really important, and that financial burden can really bring a lot on parents. Where some people say, I want to go natural. I completely understand and respect that. But sometimes there is a time and a place to say, you know what, we're ready to discuss clonidine. What are the safety effects? What are the side effects? What are the safety profile? What are the pharmacokinetics? Clonidine, I know a lot more, and I feel safer as a physician prescribing, knowing more about in that age range. That's FDA approved, as opposed to something that you're buying on Amazon.
And just, personally, that our decision to move to clonidine was not an easy one.
We dragged our feet.
We dragged our feet. We wanted to stay natural as long as possible, and like I said, so I completely understand to everybody out there, these are not easy decisions. Any other comments on this issue? You had your hand up for a long time.
Sorry, just a quick question. You mentioned Momentum to help epilepsy. Does it suffice to say that seizures are a gain of function, or is that across the always, are seizures always a gain of function?
That's a fabulous question. So and it depends on the circuit you're thinking about. So it's an easy way of making the connection that a gain of function, you're tipping that excitation-inhibition balance in favor of excitation, and therefore you're going to get seizures. But the question is, and that Steve and Catherine can talk about as well, is well, what if your gain of function is in your inhibitory circuits as opposed to your excitatory circuits? Then you're getting something the opposite. And so let's say a loss of function in your inhibitory circuits, well, that'll give you seizures too. So I think that the jury is still out on that. And so it's, I think, easier for us to say that it makes more sense to recommend a drug like memantine, which will reduce function if you know that there's a gain of function. It's easier to make that recommendation in this very gray area as opposed to saying memantine is good for what ails you if you have an NMDA receptor genetic change. Does that make sense? Okay.
Yeah, and I think I would just add that when we in the laboratory think about these gain of function, loss of function, we're always thinking in an acute situation, what does it happen to this circuit right now? But in the patient, they have undergone compensation, they've been missing, they've had that defect for some time, and although you may find a gain of function in a patient who's showing some seizure disorder, the seizures may have a focus in a region of the brain that has been rewired inappropriately and has nothing to do with the NMDA receptor anymore. And there may be recurrent collaterals and changes in other channels and other excitability factors that now drive this excitation. And that malformation, if you want to call it that, was triggered by NMDA, but it's no longer sustained by NMDA, and one would not expect memantine to do anything in that situation. And so, and we don't know.
I still don't really understand gain of function versus loss of function. What are we talking about?
So imagine a channel as a door, okay? It's the door right here. And every 15 seconds, that door opens because somebody comes through, and that's its normal function. But let's say there is a bolt that fell off or it's the wrong size up at the top, and people try to come through, but the door is stuck. And they're jamming and they're pushing, and now that door opens every 45 seconds, and only one person can come through. That would be like our channel that has a loss of function. It simply doesn't open as much. Let's say, on the other hand, that door opens and gets stuck open, and the whole crowd from the coffee comes in at once. 50 people stream through in the time one person should have come through. That would be like the channel opening and getting stuck open and not closing. And so this gain of function, loss of function, in a simple way, you just think about the ability of that little machine to pass current in the cell. And so gain means now it passes a lot more current than normal for any one of a number of reasons. Loss means it passes a lot less current for whatever reason.
I had a question about it. Does anybody look at levels of neurotransmitters and things like that? At one point, my daughter had some blood work done, and some of her levels were really like way out of like ranges. Like her dopamine was super low, and her, like, I don't remember specifics, but does anybody look at that in this group to see like if there's any commonalities, or does that make any sense? I don't know.
So it's really hard to probe your neurotransmitters. You really can't probe your neurotransmitters with a blood test. The only way to probe your neurotransmitters is actually with a spinal tap. A spinal tap, the neurotransmitters that they are probing for are actually things along the lines of not glutamate, which is the primary excitatory neurotransmitter, but other neurotransmitters that are related to dopamine and things like that. Those are the transmitters that kind of regulate the overall excitability level of the circuit, as opposed to the instantaneous changes that we're talking about. So it's not something that's necessarily done in terms of, it's not done with a blood test. It can be done with spinal fluid analyses.
Could it have been done with urine? I'm thinking there was something.
You know, there are a lot of people that are going to sell you different kinds of tests that aren't necessarily useful or helpful. I mean, there are actually some genetic changes associated with how well you make different neurotransmitters, how well your brain soaks them up after you release them as well. But a lot of those actual genetic changes, they're usually part of if you have epilepsy, those are actually on the epilepsy panels, and you might have been tested for those changes as well.
I would add, and this is similar to the protection that I pass on to you, or just wariness that I'm setting on you, that people can sell things on Amazon just like people can sell tests. And so there's a lot of tests that are out there, and it might not be a useful test because you can go and check the blood, but there is that thing called the blood-brain barrier, which prevents everything in your blood going into your brain, right? And so that's why sometimes we're not going to get a good view of what's going on in the brain by just getting blood and urine. Similarly, I hope there's no urine in my brain, so it's not equal. So just because you're looking there doesn't mean it's useful, but people might sell you on that. And so I would just warn you when people like say this is a test that we can offer, and you are a consumer and you can ask, prove it to me. What does this mean, and what are we going to use it for? Your physician and your clinician and other people should have the oath to say, if I order a test, what am I going to do with the results, and do those results matter?
I just wanted to paraphrase, and my neurology colleagues can chime in, but when I think about seizures, and I'm trying to think about this as a parent, I'm worried about my kid having a seizure, right? So I would say all of our kids probably have some EEG abnormalities. So meaning their nerve cells are communicating improperly for whatever reason, and they're not generating brain waveforms that are quote unquote normal. So they all have some degree of potential for seizures. So lots of things from my perspective as a general pediatrician, like different viral infections or bad fevers or other things can help to set off that seizure. So I think, you know, they were talking about earlier, just that NMDA problem or that GRIN2B problem is kind of that cause, but that might not be what ends up setting that off. So there's multiple things, I think, that go into this, which makes, you know, the problem solving much, much more complicated.
You missed right there, sorry.
I had a question about European collaboration. Years and years and years ago, when I contacted Dr. Lemke, he didn't even know about Simons, and then he was like, "What is this thing?" So we had gone back and forth, and now I just wondered if someone could speak to that European component, because there's a lot of things going on in Europe right now, also. And is there a connection? And is that connection Simons? And how does Simons advertise to a researcher? I just happened to stumble across Simons from a researcher from TGen, our Dr. Narayanan, and she just happened to say, you know, I'm looking at this sheet, and it just happens to say Simons, why don't you give them a call? And it was just out of the blue, and that was years and years ago. So twofold, if you could speak to the European collaboration, and then also, do you advertise to researchers across the country that our blood is available for opportunity?
So I can start and pass this on for someone to talk about Simons, but we're strongly connected to the European colleagues. We talk to Johannes Lemke probably once a month. We're on Johannes' papers. Johannes calls us when he needs anything. We share variants within the GRIN family. We just GRIN3A, this mysterious protein nobody in the research world really understands, has variants and is intolerant, and Johannes just sent us a bunch of variants saying, well, we don't know what to do with them, see what you can do. We're merging our database. CFIRV is in the process of merging our functional database with Johannes' clinical database, and of course we'll make sure all the variants he has, we now have, he has all of ours, all his clinical information is on ours. The two databases will be housed separately, but when you go to the web page, the software will just pull them up and merge them, and that way we will be able to capture everything going on in Europe. So I tend to feel that from my perspective, the North American work is well connected to Europe. We're well connected to Asia as well, and it's a very collaborative, very open set of interactions that is pragmatic. We just try to get things done as most efficiently and best as possible. You want to speak to Simons?
No, I'll pass it on. But so there have been some European clinicians that have contacted us with their genetic information so that we can, and I've passed the questionnaire that we're using to Dr. Lemke so that we can be collecting similar types of data. So it's all so that we do not miss the resource which is available, which is you to try to answer this question.
I'm going to say probably 30 seconds and then pass most of it to Jennifer back there, who knows more about the overarching Simons VIP. But Simons VIP is newer, but continuing to grow. There are some more recent advances to link up the genetic labs with Simons in being able to bridge. But I think it still is a matter of letting people know, letting clinicians know, letting geneticists know. This is a situation where I'm a junior attending in the field, and you don't get taught this in medical school. Don't get taught this in residency, and so very often parents are bringing things to the clinician, and it is a two-way conversation. It's a two-way street. So a lot of times, much of the conversations in my office are brought from the patient to the clinician. And then once clinicians know, and these training resources are brought out, especially into broader and broader communities, more word of mouth goes out. But I'll chime over to Jennifer about spreading the word more about Simons.
Yeah, so how do people find out about our data and biospecimens? So the Simons Foundation has been doing autism research for years and years and has funded hundreds of investigators at this point around the world to do various projects. We have an open RFA call for RFA every year, and so we have a group of investigators that get our regular newsletters and updates, and So when we do a data release, we usually send out an e-blast to people. But there will always be investigators that aren't part of that group that either are already working in a particular area, or maybe they're working in a related area and might be attracted into this area. So that's one thing that we want to, as much as possible, start to pull in, all right, who are the researchers who would want to know about this, and is there a way for us to reach out directly? I think the other piece is it's not always clear to people how they can use what has already been collected, and it takes some collaboration back and forth, because it's much easier to think of a project from kind of starting from scratch with your own idea of exactly what you want to look for. And it's hard sometimes to use someone else's data and then figure out how to merge it into your particular research question. So one thing, and I was mentioning it earlier, is there's another family group that we've worked with that really, they are committed to identifying different researchers that they know are working on their particular disorder and bringing them together. And that's a super powerful way to accelerate research, is that if you know that you yourself are having ongoing conversations with researchers that are interested in your condition, and then the researchers themselves are talking to each other, because everybody gets so busy, and they, you can get into your own stuff, and it's so important, and to know that, there's already collaborations going on between Europe and here is great. But that's like our number one thing going forward, is how to figure out how to get more people using the information that you guys are providing, so that can keep accelerating questions. We are also adding some additional languages closer to the end of the year or beginning of next year. So that's great. Spanish is one of them. So we're hoping to increase, because a lot of times the barrier is that there are a lot of subjects in Europe, but they don't speak English. And so, they can't, up till now, we've only been able to accommodate English speaking. But we have other groups too that said, please, can you please add Dutch? Can you please add Spanish? Because there's so many families over there that we would like to include.
I just wanted to add to that. I've had conversations in the past with, I don't know if it was Jennifer, or it might have been Lindsay from Simon's AP, where they asked what doctors I would want their GRIN2B registry information to be shared with, and I've been able to give them names of people. So as we know more European doctors, and we can also help share that information with Simon, so they know who to share the data with. And then I also just wanted to make sure that it's clear that Simon's will share data with anyone, but they have to be affiliated with is it a university or a... Yeah, it's an institutional thing. So just for your own protection, to know that we're not just throwing all your information up there on the web, that anybody can do it. So it has to be a qualified researcher, and most of the researchers that you will come in contact with are affiliated with some kind of institution, and we just have an agreement that they need to sign that says, I promise I'm not going to do anything horrible with this information. I'm going to, treat it with respect. I'm not just going to go post it on the internet myself. And, so it's just a basic kind of agreement that we're using the information in the way that you would want it to be used.
So if I could answer another part of your question. First of all, you are always going to be your child's best advocate. And so take care of yourself. But the other thing is here's not an unreal situation that's actually real. You think that your child has a particular genetic diagnosis. You tell your pediatrician, I think it's this. The pediatrician sends off the test, gets the result back, and hands you the piece of paper with no explanation about what it means. You then, being the best advocate for your child, you will go to the web and you'll find GRIN2B. GRIN2B can say, I know people that are working on this, and then they put you in touch with Simons or CFIRV and or Austin, and then that's how the whole thing moves forward. And because it's hard, we try to communicate what we think is going on and what's interesting with these different rare genetic disorders, but our reach into the community is only so far. We do our best, through presenting at meetings and papers and whatnot, and so it ultimately comes down to you as being the best advocate for your child. Sorry.
Some other places that Simons does kind of kind of get their name out is different research conferences. For example, there's big autism conferences. They'll go to those types of locations, the neurology associations, child genetics associations, to get their name out to say that,
You know, we are a presence. We want to be a part of engaging you and getting researchers. You know, we have a Simons researcher up here in the front row. Yeah, ironically enough, who now is personally and professionally related, and so it's word of mouth, but it's also you being the advocate and sharing that with your doctors and your clinicians and even parent groups.
Go ahead.
I was going to say, just related to the doctor question too, is there a way or something with our neurologists as we work with them, something that even if it's just, I would say could send them to the GRIN2B website or the foundation, give some general information, but is there more of a clinical overview that would be good for doctors to understand? Because like you said, you get this report from your geneticist, you now Google it, thanks to Liz and all the board members that we've been able to get more information, but I feel like from a clinical perspective, there's still a lot lacking in the clinical community. So we're now basically saying, okay, she has this genetic disorder, now what do we do? Or, you know, what research have you seen or other type of supplements or drugs that they may have used? But is there, you know, some sort of one pager, you know, some sort of package to at least give the doctor? I know the report that we've gotten from Dr. Trinellis' group too, that's been forwarded on as well. So I didn't know if something like that or a different type of research.
If you guys don't mind, I'll jump in and answer that one. And I would say that
that is on my list. My list of potential projects to work on next. I've seen a lot of other groups, they put together a one sheet, and then we would work together with you guys, and you would distribute this to your pediatricians, and we would have to start a whole project. We would have to get the word out and give this one sheeter to doctors, and we would work with all of these guys too to spread the word. But yeah, that is something that we would, you know, want to develop, and we'll obviously ask these guys for input, so it's not just me just making it up as I go along.
That's something that I've gotten as a clinician from other groups. This is my daughter. It has a picture of her, right? This is my daughter. Don't forget who she is. But this is the disorder she has. These are the people that you can reach out to. Give it to your teachers, give it to your therapists, like what works, what doesn't work about your child. And, you know, this is the perfect opportunity to utilize parents and researchers and clinicians who see this and say, this is what we need to look out for. Tell my pediatrician, I need to get them over to this doctor or that doctor.
I also just want to mention, I was just Googling, there is the gene reviews. I don't know if either of you were involved in writing that, but there is a gene reviews for GRIN2B, which is usually a first step when you have a certain number of patients that gives clinicians some background. So that could be a link that you put on your website too for, you know, for now.
I think partnering with whoever you trust. So for some people, that'll be your pediatrician. For some people, it'll be your neurologist or your developmental pediatrician, but somebody who you trust, and that person isn't going to know everything about GRIN2B. That's not an option right now. But it's someone that's going to be open to talking and to thinking about it and to reading. And they might not always have the answer in your 10 to 15 minute office visit, but somebody who'd be able to look into stuff on their downtime for you.
Well, a round of applause.